This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I am the voice of MDH Podcasts, Nick Andrews. And welcome to episode 80 of Blood and Cancer. I am Nick Andrews, and I'm joined by the editor-in-chief of MDH Hematology Oncology, Dr. David Henry. And Dr. Henry and I were supposed to record a couple hours ago, but lo and behold, there was a dinner party involving one daughter. And I must say that, Dr. Henry, that's always a pleasant surprise when you forgot you had a family event on the calendar.
Oh, exactly right. And I'm still at my daughter's house where we're hanging pictures. And I said, I can't leave till I have my special dessert, which she's made for us. So I said, well, I'm just going to record my podcast from this house. So that's where we're coming to you from this evening in Lower Merion.
Yes, that's and Lower Merion, of course, for those of you sports fans out there, that is, of course, the former home of basketball legend, the late Kobe Bryant. And yeah,
exactly.
Big, deep roots in Philadelphia. Interesting episode we've got coming up. I want to talk about the guest in just a moment, but I wanted to mention that we started doing something new. We've been talking about it for a while. We had a new Blood and Cancer that drops on Tuesdays. It's all news, Dr. Henry. So it's just like a nice 10 to 15 minute briefing on the top stories in hematology and oncology. It's something that we wanted to drop for you. These conversations are clinical and they get in depth, but we thought we have all this news that we can do. We might as well bring you some of it.
And I think it's a great idea because what will happen is this has come out, that has happened. Someone's talking about something, a new trial, a new study, a new drug, or like the opposite, hydroxychloroquine not working. So I think a news feed without the in-depth, necessarily needed talk with the thought leader plays a different role. And we drop those on Thursday morning, like this one. And on Tuesdays, the news feed, what you need to know.
Yeah, absolutely. Like, for example, this week we report to you how obesity plays perhaps a greater role or a bigger role than once thought in outcomes, more so than genetics in breast cancer, which is something that the big news there. That kind of thing will be in this new show on Tuesday. So the first one dropped on Tuesday, and that's something that you can look forward to. And that's why we jumped from episode 78 to 82.
And that's good point. And that's a good segue into our speaker on this podcast, Dr. Lemanne, who's going to talk to us about diet. And of course, I thought, well, just don't lose weight, keep your calories up, eat whatever you want before you come to clinic, get your therapy, go home. And we talked a lot about sugar. And of course, many of our listeners have had patients say, oh, I'm not going to eat sugar because cancer cells eat sugar. Well, every cell eats sugar. You have to have it, but there's a way to do it properly and improperly. We're going to talk about insulin, how too much, too little, just right is important for your total package of cancer therapy. Metformin has been circling around for a while. Clinical trials goes into of how that might be useful in treating cancer patients. And of course, not to eat whatever through some of the goods and the bads, and where to find more information.
Yeah, and that's so important. This is one of the first ones we've done where I think that my mouth was open the whole time. The sugar, like the implication is that eating correct diet can actually impact your outcomes with your cancer diagnosis, and that Metformin, a drug that has been around forever, might have some clinical impact here. Is just incredible.
Very, very useful, very interesting information. And, it's not just a diet, it's an important part of your therapy.
Yeah, and the other aspect of this, Dr. Henry, that I wanted to touch on, and this was mentioned in the interview, is that it gives patients a semblance of control. You're diagnosed with cancer, you think, this is like, what can I possibly do at this point? Well, apparently there is some control in the patient's hands, and that's must feel, I guess, psychologically like a good thing.
Well, and that must come up at least every other visit. You're doing this for me, Dr. Henry. You're giving me this therapy. I have the chemotherapy nurse. I'm supposed to watch my temperature. But what can I do to beat this cancer? I want to fight along with you. And here is something clearly you eat every day, and we don't want you to lose weight. We don't want you to gain weight. We want you to do proper diet that you'll hear on this podcast. So I think this is really nice for the patient to take part in the package of therapy.
And you can always contact the show at podcast@mdh.com. Interview coming up in just a moment. I want to say, Dr. Henry, so we're investigating something. Someone emailed the show, a young trainee, a while back and suggested a topic that I think that we're going to bring up, and that is how exercise can be incorporated into one's therapy as well. That could be coming up later on this summer. And if you have any similar thoughts, you can email the show, again, podcast@mdh.com, and you can find the Dr. David Henry on Twitter, at David Henry MD.
And as you mentioned, that same webpage has show notes, has this podcast and older, going back 78, now 80 shows, if you'd like to search and perhaps listen to something that's not so old. We have been doing this like a year plus, I think.
Yeah.
So
Unbelievable.
A lot of it's still fairly fresh.
Yeah, absolutely. So coming up right after this, Dr. David Henry and Dr. Dawn Lemanne. David, I hope you enjoy that dessert.
Thanks so much, Nick. I'll let you know. I'm your host, Dr. David Henry, and you're listening to the podcast entitled Blood and Cancer. And I'm delighted to be talking today to Dr. Dawn Lemanne, who is an oncologist, and she's director of the Oregon Integrative Oncology, a clinical assistant professor of medicine, University of Arizona, in very warm, steamy, probably Tucson, Arizona. Dawn, welcome to this podcast today.
Oh, thank you for having me.
Well, you're very welcome, and I, as I mentioned before we started recording, I've been looking forward to this because your in particular area of interest is integrative oncology and diet, and this comes up almost always with our patients who want to, of course, take some kind of control over what's happening to them as we give them various therapies. And what can I do, doctor? Can I eat this or not eat that? What's important to do? So why don't we, and we have a couple areas that you've done research in, so why don't we start off with that global question that we get in the clinic that you get and answer. What could our patients do as they're getting, for example, the common cancers, lung, colon, breast, metastatic or adjuvant? What should they do with diet to help themselves get through this?
Well, this is my favorite question, and it's been a question that I've had my entire career, and it's very obvious to people that food must play a role in general health. And until recently, we oncologists, I think just because we've had so much to do, we haven't had time to take a lot of close looks at how food and diet interact with our cancer patients' health. And now that we've got more tools to be able to do that, we're taking a closer look and we're finding out a lot of really interesting things. And some of the most interesting things have to do not with so much what you eat, but although that is important, very important, and we can talk about that for a long time, but also what you don't eat and when you don't eat.
Yeah. So
not eating is, it turns out to be really, really important in affecting cancer treatment efficacy and our overall health. So those are some things that really have struck me over my career, and things that I've found really interesting. And it is true that patients can take control of that area of their treatment. They can't really prescribe their own chemotherapy usually, but they can take control over what they eat and when they eat and how they eat and make a big difference.
Are there certain they talk about my immune system, doctor, I want to stimulate my immune system, I'll take this or that, and St. John's wort comes up a lot, which is the one that always gets my attention because that can interfere with absorption or activity of things. So are there some do's and don'ts you recommend eat and not eat? And doctor, how can I help my immune system?
Sure. So the immune system is really important. I think one of the things that I'd like to stress with my patients is that just a blanket stimulation of the immune system isn't really that possible, and perhaps isn't even that desirable. So, for instance, after an operation, there's a certain type of immune stimulation that may actually increase the growth rate of at least some cancers. So stimulating the immune system isn't really the goal that I tell my patients to aim for. So I think that aiming to quiet the overactive and perhaps not so helpful parts of the immune system is really important. And stimulating the right parts of the immune system at the right moment is also a good plan for cancer patients. So, for instance, fasting right before and during a chemotherapy infusion may be really helpful because it puts part of the immune system that might be damaged by the chemotherapy, it puts it into kind of a dormant state, puts it to sleep. And that can help protect that part of the immune system from the deleterious effects of the chemotherapy, while also making the cancer a little bit more vulnerable to the effects the good effects of the chemotherapy. So fasting is something that patients can do a lot of times. And I follow the research out of the University of Southern California, I think published in 2017 by Tanya Dorf, a wonderful oncologist in Southern California. And she was working with the Longo group down there, Walter Longo, who's done so much work with fasting in cancer. And they found that 48 hours was the sweet spot for patients on platinum-based chemotherapy regimens. And the way that they did this was to look at patients fasting for 24, 48, and 72 hours around their infusion. And to make a long story short, 24 hours before and 24 hours after, for a total of 48 hours, seems to be the sweet spot to decrease DNA damage to certain immune cells. And also animal studies show that length of time is pretty nice for increasing the efficacy of chemotherapy itself.
Well, that's really interesting because now I've been around long enough to treat patients with testicular cancer back in the day with cisplatin, and they were horrendously sick because we had no antiemetics that worked, and so we would tell them not to eat. Now, of course, we have much better antiemetics, and we tell them okay to eat. So maybe we've come full circle. You think, for example, cisplatin and DNA good cell damage is best protected by some fasting before. And when you say fasting, everything, what can they and can't they eat?
Sure. So that's a great question. So fasting has a lot of different meanings depending on who you ask. And when I talk about fasting, I'm talking about no calories. So fluids, yes, as long as they have no calories. So I recommend my patients take water as they like, drink to their thirst, and maybe a little bit extra if they're on platinum, of course. And also they can, if they like, have caffeinated beverages, tea, coffee, as long as there's nothing in them.
No sugar, so coffee, tea,
no sugar,
yeah.
No cream, right. But there's no calories in those drinks, or negligible calories, and they can soften the appetite if you're having a hunger pang, give you a little energy, and make the fast a little bit easier. So yeah, no calories, and just fluids without calories.
And this would be maybe a global recommendation, all chemotherapy, or certain chemotherapies that you think this is better able to help protect normal cells?
Well, that's a really important question. We have data in humans only for certain chemotherapies, and the Dorf study that I just mentioned was specifically looking at platinum-based regimens. I do use it in other regimens. We've looked at it in animals in a wide range of drug classes. So things like adriamycin, a lot of the emetogenic chemotherapies, cyclophosphamide. I use it in those patients if they're able to tolerate fasting. We can talk a little bit about what makes a patient a good candidate for fasting. But I use it in several classes of chemotherapy regimens, typically the ones that are immunosuppressive and emetogenic.
Okay. So then I wanted to move next to, I've read some of your research and publication, and the IGF, the insulin growth factor, if I've said that acronym correctly, and its role in cancer therapy. Could you discuss a little bit about that, what you've learned and found and written? So
IGF-I is really important, and it's a double-edged sword. And thinking of a sword as a tool in a good way, you don't want to have too much, and you don't want to have too little. In the overall longevity picture, older people who have higher levels of IGF-I, by older I mean elderly, maybe 75 and above, actually do much better. There's less muscle wasting. There's a better retention of cognitive abilities with a nice high IGF-I level. However, IGF-I is a growth hormone, and it's related to the several hormone growth hormone pathway. And when it's high in middle age, that seems to increase the risk of cancer. When it's high in a patient who has cancer, it may be, and this is by no means conclusive, but research is giving us suggestions that we'll need to follow through on, that perhaps lowering the IGF-I level in some of these cancer patients may improve their survival. So the IGF-I level is easily measured with a blood test. And I tend to look at the range of the normal range for that particular laboratory, and I like my patients to stay down in the lower half of that normal range. And if they're pushing the upper limits, we try to bring that down. And one of the best ways to bring that down is by overnight intermittent fasting of 13 hours or more.
So there's no drug to lower, you just have them fast. That can lower the IGF-1.
Yes.
Okay.
There are drugs that affect this, somatostatin, octreotide, those kinds of things work in that system, but I wouldn't recommend taking a drug when, with all of the side effects that are attended to those drugs, when we could possibly do it very simply and without any side effects. In fact, probably making a patient feel better just with some prolongation of the overnight fast that they're going to do normally anyway. So instead of, 10, 11, 12 hours between supper and breakfast, we move it to 13, 14, even 15 or 16 hours if the patients tolerate it. And most patients do. They kind of like it. It takes some pressure off their breakfast schedule.
Right.
I'm not a big breakfast pusher. I say you don't have to eat breakfast if you don't want it. If that prolongs your overnight fast, you're probably doing yourself some good in terms of that IGF-1 level.
Well, now, continuing the sugar theme, there's data on metformin and cancer therapy. Could you comment on that?
So there's wonderful data looking at cancer in diabetics and dividing those in a retrospective way into patients with diabetes who are on metformin when they were diagnosed with cancer versus those who are not on metformin when they were diagnosed with cancer. And the metformin takers do better in terms of cancer survival. Now, these are diabetics, so the question then comes up and is now being looked into, and as you mentioned, by somebody there at your institution, University of Pennsylvania, looking into whether giving metformin to patients who don't have diabetes, at least not an overt diagnosis of diabetes, but do have cancer, to see if this actually may impact their survival as well. And I think that that's a really interesting line of research. I think that metformin is safe. So I actually will, even in my patients who don't have diabetes, I will check their A1C and I'll check the fasting insulin level. And if there are any hints of problems, if we're getting an ANC that's above 5.8, 5.9, something like that, and we have a fasting insulin that's in the mid range of high, say not abnormal, but say pushing 20, something like that, we first try to get that down with diet. But if it doesn't come down quickly with diet, I will add some low-dose metformin to those patients. And if they tolerate it, we'll continue it as long as we need to.
Fascinating. Do we have any idea how it works to do this cancer improvement thing?
So metformin, prevents a rise in blood sugar. It doesn't really lower the blood sugar specifically in most people, but we think that keeping the blood sugar low and preventing some spikes may help suppress insulin and insulin-like growth factor levels so that those two entities don't stimulate cancer growth as much. So we think that that's how it works. As far as the actual nitty-gritty, you're beyond my wheelhouse. I know that people are looking at the microbiome and how metformin impacts the microbiome, and it may exert some of its effects that way. It may act directly on the liver and glycogen release. So those are some of the ideas that are floating around right now.
Well,
but you may know more about that than I do at this point.
Well, that makes me wonder, patients will say to me, you're at the end of the whole interview and we're getting started on therapy, doctor, I know sugar, cancer cells like sugar, so I'm just not going to eat any more sugar. And I go, oh, that's crazy. You can't stop eating sugar. So am I wrong? Should they markedly reduce sugar intake?
Well, I think that the answer to that is it's not really about sugar. It's about the blood glucose level. So if a patient can eat 100 pounds of sugar a day and their blood glucose is staying nice and low, and by that I mean it's in the low 80s, fasting in the morning, and it doesn't go above 120 postprandially, I don't think they have a problem with glucose.
I see.
But those excursions, the glucose excursions that a lot of us get after a starchy or sugary meal are problematic. So some of us can spike up to 200 after a plate of spaghetti or something like that, and we don't really think that we're diabetic. But that if we do have some cells that are avid for glucose and do better if they're cancer cells, do better if we provide them with plenty of glucose. Yeah, I do think that could present a problem. So one of the things that I like to do with patients is give them a 24-hour subcutaneous glucose monitoring system. and let them go around for a week or so and see how high their blood sugar spikes after meals. Mm-hmm. And that's pretty informative. And it's often very surprising to people how they do get into the diabetic range temporarily. Ordinary people, not overweight and without diagnoses of diabetes and kind of normal A1Cs, but they can spike up to 200 pretty regularly if we actually look for it.
You know, the technology to monitor your sugar has so far advanced. I've recently seen on television, there's a little dot size of a wafer that you attach to your arm, and then you wave your iPhone over it, and your sugar pops out.
Those kinds of things are fantastic. You know, I think those are great tools. I hope we have those kinds of devices for measuring just about everything soon. And if a patient can get use of one of those devices, those can be very informative and very helpful to patients who are worried. They may be worrying for nothing. You might be worrying for nothing about glucose, but we can actually take a look now, thank goodness, and see where we're at. So that's brought a nice, powerful change to patients' ability to monitor their own health and affect change.
Well, Dawn, this is really interesting. If listeners want to read more, we're going to put on our website some of what you've written. Any other places you might steer them to Sentinel articles or reviews of diet and cancer?
Sure. So I think that the work of Walter Longo, as I mentioned, out of the University of Southern California, is very interesting. I think there's a lot of interesting work going on now with repurposed drugs. One of them is Metformin. And I do really think that sensing devices to monitor one's own glucose level in real time will provide a lot of feedback for patients that they can then act on right away, and that will immediately help them get control of their blood sugar. If cancer is an actual problem or a worry for them, that may be something they'd like to do.
Well, you know, I can't thank you enough for this. I've really learned something. As we began, patients want to, at some point during our visits, say, you know, how can I control my cancer, the diet, my immune system? And I've kind of rolled my eyes and go, oh, you know, don't worry, just you can eat before chemotherapy, eat after chemotherapy, and just eat a healthy diet. So I think tightening this up with research like you've done and continue to espouse and discuss and to tell us really makes a big difference. So I want to thank you very much and remind our listeners that we've been speaking with Dawn Lemanne, who is a director of the Oregon Integrative Oncology and a clinical assistant professor of medicine at the University of Arizona in Tucson. And you can also listen to this or archived podcast on our website, mdedge.com/hematology-oncology. And we'll have some references that we've discussed today and some show notes to get some bullet points of what we've discussed today as well on the website. So, Dawn, thank you again for taking the time to discuss a topic which I should pay more attention to.
Thank you so much for having me on, David. It was a pleasure.
You're very welcome, and thank you all for listening.